Allergic rhinitis. Etiology. Allergic rhinitis is defined as a symptomatic nasal disorder brought about by IgE-mediated inflammation of the membranes of the nose following allergen exposure. The classification of allergic rhinitis is based on symptoms and quality of life parameters. It is subdivided according to duration and severity into intermittent or persistent, and mild or moderate, severe, Fig 15. Between allergic rhinitis and asthma, with both conditions commonly coexisting. Patients with allergic rhinitis have inflammation of the lower airways, and in patients with asthma, the presence of allergic rhinitis is common. Both allergic rhinitis and asthma represent allergic conditions with shared components of airway hyperresponsiveness. Moreover, patients who suffer from both allergic rhinitis and asthma far exceed the overall prevalence of asthma in the general population. Indeed, allergic rhinitis is known to precipitate and exacerbate asthma. Therefore, both allergic rhinitis and asthma represent a spectrum of allergic airway disease extending from the nose to the lung, the so-called unified airway. Known triggers of allergic rhinitis include the following: aeroallergens, domestic animals, house dust mites, insects, molds, plants, and pollens. Pollutants, automobile contaminants, diesel exhaust, domestic allergens, gas pollutants, oxides of nitrogen, ozone, sulfur dioxide, and tobacco smoke. Drugs, aspirin and NSAIDs. Occupational factors. Latex allergy. Clinical presentation. Patients present with sneezing, itching, watery rhinorrhea and nasal obstruction. Physical signs. Look for nasal polyps that can both cause and exacerbate rhinitis. Investigations. The majority of patients are treated with success empirically. For patients who are refractory to therapy, consider the differential diagnosis below, and also consider occupational history, skin prick testing, FBC, and eosinophil count. Differential diagnosis. Other non-allergic causes of rhinitis include infection, nasal polyps, foreign bodies or anatomical variants, nasal tumors, granulomatous diseases, and vasomotor, secondary to over-the-counter medication, and idiopathic factors. Treatment. Allergen avoidance, although this is not always possible. Topical, nasal, steroids are often very effective. Side effects are local irritation and nosebleeds. Check for compliance and technique if there is failure to improve. Oral antihistamines. Warn the patient about the sedative side effects of some preparations and interactions with other drugs, e.g. terfenadine with erythromycin results in prolonged QT interval. Chromoglycates. No major side effects, but require frequent use. Eye drops are particularly effective in allergic conjunctivitis. Oral leukotriene receptor antagonists. Immunotherapy. Desensitization is sometimes possible in selected patients. The technique must be performed in specialist centers.